My name is Harold Bays. I'm Medical Director and President of the Louisville Metabolic and Atherosclerosis Research Center, located in Louisville, Kentucky. And I run a research site. I've been an investigator somewhere over 500 clinical trials. Yes, I'm a diplomate of lipidology, but also a diplomate in obesity medicine. So for me, there's a crossover between obesity management and cardiovascular disease risk prevention. And so I thought what I'd do is just give a very brief presentation, and basically this is for you to ask questions. So as you're thinking about questions that you might have, particularly about DEXA scans, body composition scans, then this is the time to do it. This is the time to focus upon the questions and not so much of my presentation, okay? And you send them through the Q&A panel on the right side of your screen. So here we go. This is a picture of my research site right there. As we all know, the higher your coronary calcium scores, the higher your risk for cardiovascular disease. The radiation exposure for coronary calcium scoring is pretty low, somewhere around 1.5 millisieverts. It's even less than that with DEXA scans. Okay. So it's a very valuable tool. It's in guideline recommendations, very helpful. There are some barriers. It's not widely available, and in certain places, certainly not at the point of care, because you got to have a CT. There is some radiation exposure. Many times this is not reimbursed by insurance. And I guess if I had to think, the biggest limitation is that you can't really follow coronary calcium scores longitudinally once you have a reasonably positive results. Because as you know, if you have coronary calcium and you get put on a statin, the coronary calcium could actually get worse. So it doesn't really reflect risk after that. What about obesity and DEXA? Well, the issue with regard to obesity and DEXA, as we all know, is when you have dysfunctional fat or obesity that impairs the functionality of body fat, fat cells, and adipose tissue, you get immunopathies and endocrinopathies, and you also get increase in heart. You also get increase in fat around the heart. You get increase in visceral fat, increase in muscle fat, increase in hepatic fat, these types of things. And if you get that increase in epicardial fat, isn't it interesting that yes, that can contribute to heart failure with preserved ejection fraction, what we call HFpEF, atherosclerotic cardiovascular disease, dysrhythmia, fatty infiltration of the heart, but you also get increased coronary calcium. So there's a synergy there. There's an alliance there between, the epicardial adipose tissue and the results that you can get from the DEXA when you look at things like visceral adiposity. I gave a presentation to the National Lipid Association a year or so ago, and I got done with my presentation. I thought I did a really good job. And then people started raising their hands. They're like, but I thought DEXA was for bone. And that kind of just blew me away because I do this all the time. I do it within the context of research, but we also do DEXA scans on both patients with obesity. We do a lot of DEXA scans on athletes. So for me, it's just something I do every day. And I did not consider that some people didn't know that DEXAs are not just for bone mineral density. DEXAs are very good for assessing percent body fat, android fat, visceral fat, lean body mass, these types of things. And that's important because, again, there's correlation between visceral and epicardial fat. They both have the same mesodermal embryonic origin. Both are associated with coronary calcification. What I would say is the difference is once your coronary calcium is positive, you can't really follow that longitudinally, but we follow DEXA scans longitudinally all the time. Some of you might ask, well, do you have to do DEXA? I mean, can't I just do something else? Can't I just do calipers or bod pods or bioelectrical impedance, or for those of you that do it, underwater weighing, or these types of things? I'm not sure too many of you are doing deuterium dilution, but if you are, then there you go. And you could do those things. It's just that DEXA, I think people in obesity medicine would consider to be the gold standard, particularly when it comes to assessing the visceral and android fat. Now, some of these other measures are pretty good for percent body fat, but hopefully this is the one of the standard definitions for percent body fat. But hopefully at the beginning of the year, we're going to change that and have it more clinically applicable to patients with obesity. If you can see here, this classification put out by the American Council of Exercise Classification goes straight from acceptable to obesity with no room for being overweight. And that's just unkind, I think, and not something as useful for non-exercise folks. I mean, just for regular folks, I think it's better to have maybe a little different classification cutoff points. And then finally, the last thing that I would say is that when it comes to android and visceral fat, a lot of people say, well, great. So let's say I get a DEXA scan, and let's say I find out what the visceral and android fat, those measures are. What on earth does it mean? What does it mean? Well, here are some cutoff points by the Obesity Medicine Association. It's in the obesity algorithm, for which I am the medical writer. And your optimal visceral fat would be less than a pound. So we see a lot of women who have no detectable visceral fat and even have percent body fat like over 40%. Okay. It's just, a gender advantage. That's just a difference, a fundamental difference among the sexes. And one could say that there's a correlation between that increased risk at the same age of atherosclerotic cardiovascular disease for men versus that of women. And then what about android fat? And there's the average android fat for adults, but where you would like for it to be is less than 3 pounds of android fat and less than 1 pound for visceral fat. I think that's just the conclusion based upon the existing data that's out there and our clinical experience. And with that, again, I know it's very brief. Not a whole lot of information there, but at least for the folks that maybe haven't done DEXA scans or and such, or maybe even coronary calcium scores, this is the opportunity for you to ask questions about these procedures. So if you have any questions, again, click on the question and answer thing, and I'll be happy to answer them. So Amina, have I told people the right way? Because I'm not seeing any questions or answers here. There we go. Okay. Yeah, they're coming in now. All right. So again, feel free to ask questions. That's what the next, I think, 15 minutes are for. All right. So the question is, what options do you suggest how to get trained for using DEXA? Very interesting question. The fact is, because it does have some radiation, you do have to have a specific training and get licensed for it. So you have to check out with your state. There are educational programs that are made available. But sometimes they're really hard. And sometimes they want you to go through these massive classes, 2-day, all-day sessions and all these other types of things. So it can get a little bit involved. But I would just contact your state and the people that manage that types of thing and see exactly what's required. Okay. Would you comment on using the exam using DEXA? I have found using DEXA to be extraordinarily complementary to both the physical exam, history. The one thing I will tell you, DEXA is unforgiving. Okay? It is unforgiving. I mean, again, we see a lot of athletes and these people, they'll come in and they'll say, I got this new training program. I want to patent it. And presumably they're doing this because they feel like they can come up with an exercise program where you don't have to do as much exercise, but still achieve the same sort of percent body fat and whatever. And inevitably, they come back and their lean body mass has gone down, percent body fat has gone up. And so, it's unforgiving. And the other thing I would say is if you get your percent body fat done by other measures like a bioelectrical impedance or particularly calipers or whatever, don't be surprised if the DEXA is 10% greater percent body fat than some of these other measures. Again, DEXA, very unforgiving. I mean, it's accurate, but unforgiving. All right. Is there still concern about doing coronary calcium scores in individuals younger than 40? I mean, I think you have to use your kind of clinical judgment. I think if you've got a patient at atherosclerotic cardiovascular or coronary heart disease risk, then as far as I'm concerned, as long as you've discussed it with the patient and you know what the potential advantages and disadvantages are and such, I mean, look, again, I think a lot of the newer coronary calcium scores, again, the radiation is really not as much a concern as it would be, say, for example, total body, some of the older total body CTs. I mean, that's doesn't have anything to do with coronary calcium, but I think that's what people think about when they think about radiation. So there's that, okay? How does long-term statin treatment affect calcium scores, coronary calcium scores? See, that's the point, isn't it? Is that, let's say you have a patient and you're on that edge and you're not sure whether you want to start statin therapy. And you do a coronary calcium because you're following the guidelines. And you do a coronary calcium and it comes back pretty positive. Well, the good news is that, yes, then that should sway you towards initiating statin therapy, right? That's a good binary switch to decide to go on with the coronary calcium. But once it's positive, so you got an overweight patient that comes in, not sure if they needed to be on statin, they got some risk factors, but you go in and do the coronary calcium, it's substantially positive. So now you put them on a statin, but now how are you going to follow them longitudinally through these types of cardiovascular disease imaging studies? And I would say a DEXA is an excellent way to follow patients, particularly if you're going to follow visceral and android fat. Because again, remember that I think there's this correlation between the epicardial fat and the visceral fat. But the problem with coronary calcium score, it's not a problem. The issue with coronary calcium is once you put a person on a statin, the calcium scores may actually go up. So it's just really, I just think it's coronary calcium scores, if it does have a limitation, it would be in patients who have positive results who then get put on statins. I just think that it's difficult to see how that's going to be helpful on a longitudinal basis, okay? How does weight loss affect visceral fat? Outstanding question. That is just an unbelievable question. Because back in the day, when we were doing all these kind of studies on the PPAR alpha gammas. And PPAR alpha is the fibrates, PPAR gamma were the thiazolidinediones, the diabetes drugs and whatever. But the idea was that these drugs were going to decrease your visceral fat. That's what you heard. Or sometimes you hear, if you gauge in physical activity, that the first fat you're going to lose is in the visceral region. Folks, I don't see the evidence for any of that. I mean, I think you'll have a proportionate decrease in visceral fat if you put somebody on thiazolidinedione, but that's only because you're increasing, as you know, PPAR gammas, thiazolidinediones, they increase the amount of your functional fat. So you just have an increase in your peripheral subcutaneous fat, and then proportionally there's less visceral fat. But so how do I directly answer the question? I'll tell you exactly how I would answer the question is, I think it very much depends upon the individual. So if early on you gained weight in the apple region because you're a man, right? Because you got one of those Y chromosomes and whatever, and you gained it proportionally in the visceral region, my best guess is if you start losing weight, you will disproportionately lose visceral fat because that's where you gained it. And it's the same thing with women. If you have a woman and she has, we just saw this last week, but I've seen it before, 40+% body fat. For those who don't know, that's a fairly high number, 40% body fat. And no detectable visceral fat. And again, I've only seen no detectable visceral fat in maybe 2 men out of all of them that we've done. I'm talking about athletes. We've done a lot of athletes. I've maybe seen it twice in men, but I see it all the time in women. So if they don't have any visceral adiposity that can be detected, then clearly if you start losing body fat, Where's it going to come from? It's going to come from the peripheral subcutaneous adipose tissue. So I think it has a whole lot to do with genetics, has a whole lot to do with your physiology. Maybe it has to do with concomitant medications. But this idea that you can target weight loss to certain parts of the body, I think that's been debunked. The only exception, and this is what I love about this question, because I wouldn't have remembered this, but this is so key. The only possible exception that I've seen where you could have a disproportionate reduction in visceral adiposity is hula hoop. Okay, hula hoop. I don't have a camera on, but I got a hula hoop here in my office. I read that in an article, and I'm like, well, that's what I'm going to do. Periodically, I'm going to get up and I'm going to do some hula hooping. Now, let me be 100% clear about this. It took me about, 3 months, to really start doing it. And then I still haven't been able to go counterclockwise, but I can go forward and backwards. I can go to one side. Still haven't gotten the other side down yet. It takes me, it took me a long time. So I'm not saying I'm good at it, but I can sustain hula hooping for as long until I get tired. But according to the data, that you can increase the musculature in the core region and perhaps decrease visceral adiposity with hula hoops. And the idea that you can have that right there in your office, I think that fits the paradigm of taking a break from physical inactivity. And oh, by the way, hula hoop improves lipid levels. Okay. Are DEXA body for body composition covered by commercial or Medicare insurance? I think in most cases they are not. But for us, we charge $125 for the first DEXA scan and then $90 for each follow-up one. So, I don't know how much pizzas cost where you are, but there are certain places here in Louisville where you order pizza, it ends up being $70, $80 or something. I think everything's relative. And if you're only getting a DEXA for body composition once every 6 months or a year, we got some people want to get them like every month. We tell them no. We're not so much concerned about the radiation. We just think that's not very smart to have it that many times. Okay. Does visceral fat always correlate? Well, of course, it's not always going to correlate with coronary calcium. Nothing always does anything. I'm just saying in general that they do correlate. Okay. Does DEXA scan get ordered in the same way as bone density? I think you have to check with well, first off, that's a great question, because if you look up DEXA in the internet, not that many people do the body composition part. They'll do the bone part. So you need to specifically ask whether they do body composition. We've had people drive for 3 hours from the East Coast. I'm in Kentucky. We're not really near an ocean, but we've had people drive as far as 3 hours to come here because we do the body composition part. We just had a woman that flew in a private jet to get a DEXA here. Now, that's the great part of the story, but the truth is she came in to see her daughter, and both of them got it. And I'm just assuming that her private jet landed to meet with her daughter and not get our DEXA, but I could be wrong. How can I interpret the coronary calcium score in a patient using a statin? Well, once you get a positive coronary calcium score, that's all the interpretation you need. They're at risk. And there you go. And I don't know that anything you're going to find after having a substantially positive coronary calcium score, I don't know that there's any sort of subsequent coronary calcium score that's going to give you longitudinal diagnostic information. What about using BMI versus body fat percent? Okay, great question. First thing is, the body mass index is just simply your weight, kilogram per meter squared, right? So its metrics include your body weight and your height. So I can't tell you how many patients we've come in, and I hate to say this, I'm not trying to get all political here or woke or anything like that, but it is true that we have had women that have come here that have been told they were overweight because they're athletes and because their BMI was elevated, when in fact they have hardly any visceral fat and very little android fat. Why? Because they have a lot of muscle mass, so their BMI goes up. So for the general population, BMI is fine. For most patients, BMI is fine. But for patients who may have sarcopenia, decreased muscle mass, or patients who are engaged in resistance training, it's not good enough. And so the next thing would be percent body fat. But even then, that's more of a descriptive. Percent body fat is more of a descriptive term. It tells you, again, how much of your body composition is fat. What I think is really prognostic is the degree of visceral adiposity and android adiposity. And that's why you have to ask, not only does the DEXA do body composition, but does the DEXA do visceral android fat? Because not all of them do. Is the coronary calcium result overestimate risk in a patient on chronic statin treatment? Well, I don't know. I mean, if you had a person that was on statins and you did coronary calcium and it was low, I don't think that that's overestimating anything. On the other hand, if it comes back high, I'm just not sure. If you didn't have a prior one, I'm not sure what that tells you as far as the implications of what the statin is doing or not doing. Do you consider DEXA or CT the gold standard for body composition? I consider DEXA. CT is a good measure, but DEXA is a whole lot less radiation, and it takes just a few minutes, and it gives you fabulous pictures and analyses and these types of things. So here we started out, we didn't have any questions, and now I got like a million. And I'm not going to be able to answer them because we only have like a minute left. Okay. Any differences in DEXA standards for Asians versus Caucasians and African Americans? That is such an unbelievably great question. There should be, shouldn't there? There should be. It's just that we don't really have standards for DEXA for anybody, but hopefully that's going to change after the beginning of the year. The stuff that I've shown you is stuff that's probably never been seen by, most anybody. And so we're going to really, I think this is going to be the next new thing. For those of you who don't know, there are all kinds of anti-obesity drugs in development right now for which there are cardiovascular disease outcome studies. So lipidologists, and they do affect lipids. So lipidologists are going to have to become very acutely aware of these agents because they're going to become a mainstay of how you treat patients with dyslipidemia.